Hi, good afternoon. My name is Mary Charlo Galella. Thank you for joining us for the last workshop in this year's seminar. Before we get started, I just want to remind everyone to please use the chat to sign in. This is our virtual sign-in sheet. If you need to request your CEUs, remember that you must attend this workshop in its entirety. And for some disciplines, you need to complete a post-test. I will be entering that link in the chat for your convenience, or that can be found in your emails that you probably received yesterday. Zoom will provide a report on how long each of you stayed in the workshop, and CEUs cannot be given if the attendance is not verified. So for today's workshop, we're encouraging questions. You can leave them either in the chat or in the Q&A section. The topic of today's workshop is neurofatigue, the implications and treatment approaches following brain injury. Our presenter is Dr. Erin Foltz. Dr. Foltz is my colleague, a neuropsychologist at the Center for Brain Injuries at the JFK Johnson Rehab in the Hackensack Meridian Health. Dr. Foltz specializes in the comprehensive evaluation and treatment of traumatic brain injuries. She completed her internship at NYU Langone Rusk Rehab and her postdoctorate fellowship at the JFK Center for Brain Injuries. She earned a bachelor's degree in philosophy, neuroscience, psychology at Washington University in St. Louis, and her doctorate in clinical psychology at the Long Island University. So take it away, Dr. Foltz.
Thank you, Mary. Hi, everyone. As you can see, I'm here today to talk about neurofatigue. This is a topic near and dear to my heart because this is something I see almost the most often in evaluations and in treatment. And really clinically, I find that it's underestimated, underreported, and definitely misunderstood. Very well understood by the patients who experience it, but they often don't have a name for it or an understanding of what it is, and their providers don't either. So that's what I'm here to talk to you about today. Thank you for joining. A quick kind of order of business. When I do say brain injury today, I'm typically being pretty broad. I treat the full range of brain injuries from the mild TBIs, concussions, to moderate and severe TBIs, strokes, etc. And so sometimes I have specifics that will highlight those individually, and I will call that out, but really neurofatigue is something that can be experienced across the spectrum here. No real disclosures except that I am an employee at JFK Johnson Rehab Institute. I am going to go off my video here as we get started so you can focus on the slides. So why is fatigue such an important topic for us to discuss? Well, it's one of the most reported and one of the most long-lasting symptoms following brain injury. People can start to notice this within days, or it might take some weeks within injury, and it can persist for years. Fatigue after brain injury is associated with a lot of issues: higher levels of disability, lower quality of life, mood symptoms, sleep issues, pain, cognitive complaints is a big one that I see. And this can impact return to work and can even have people really have to go on SSI or disability because of the fatigue specifically. As you can see here on this slide, I have a range of the different prevalence rates, and I'm breaking it down by different type of injury. The primary takeaway, though, is how common this is, again, across all brain injuries, and how long it can persist. You will see a wide range. For example, after TBIs, 21 to 73%, and in a couple other areas. Why I think we see this significant kind of range is it really depends on how studies were capturing or quantifying fatigue, if they were even capturing it all. My clinical inclination is really to sense that this is happening more at the higher end of these statistical spectrums here. And you can see that really these persisting levels, it's reported in 70% 2 years after a TBI, 60% 5 years, and even 57% of people 10 years in some of these studies. And after stroke, 68% reporting that fatigue from 3 to over a year post-stroke. Fatigue is common in a number of other neurological conditions as well. A few important notes to make early on is really that the type and severity of the brain injury that we see is not really been found to correlate with the severity of fatigue. So with TBI, the severity of the injury and the age of the individual doesn't tell us what kind of fatigue to expect. With stroke, the infarct location or size or type, the severity of impairments afterward, also not predictors of fatigue. And I think why this is important to take away is really providers and caregivers and family members, we should not be making any assumptions about the severity of fatigue compared with the injury severity that we see coming in. This means that someone might have that mild TBI, or they might be told their stroke was small or isolated, anything like that. It does not mean that that person will necessarily feel any less or particularly more fatigue than someone else. Every brain injury is unique, and just like every brain is, so we need to treat it as such. What is in a name? Fatigue, despite its prevalence, it's been hard to pin down a real definition of it in the literature. You can see some definitions captured here. This first one, a subjective lack of physical and or mental fatigue perceived by the individual or caregiver to interfere with activities. This was really designed, built around a multiple sclerosis, MS experience, but why we like it and why the literature often likes it is because it is capturing this perception that it does matter how the person is experiencing it. And we also see it's capturing the physical as well as the mental. And you can see the second definition also found in the literature is very similar, right? This is a mental, physical, or maybe even both exhaustion and tiredness that can persist. When we get technical, you can see that there's a number of different types of fatigue, right? Physiological, really related to the body. Psychological, more of a mental, emotional type of fatigue. Pathological, something that's not really helped by taking rest. It is a state of fatigue. Something primary means it's directly related to the condition. And what we're talking about today would be the brain injury. Secondary would be more related to, again, a secondary intermediate factor like poor sleep, another health issue. A central fatigue is associated with changes really in the nervous system, right? We have these neurotransmitters, more of a cellular level here, versus a peripheral, which is more related to a physical change in muscle function, kind of physical limitations. So all of these are out there, but when we talk about fatigue today, we are looking at something pathological. It is not helped by rest. It is primary because it is related and resulting from the brain injury itself, and it is central. But that's pretty technical. So that is not what I weigh my patients down when I talk to them about fatigue. Instead, this is how I break it down more often, which is these four main subtypes of fatigue. The first, physical, really ties back to that physiological we saw on the more technical slide. This is a physical exertion. The muscles are tired, the body is tired, and how you recover from that is you rest the body, stretch, nap, take a break, put a heating pad on, right? By resting the body, the person feels better. There's a stress fatigue. This is something that's resulting from chronic stress. This is something a number of us have probably experienced. For example, you're studying for a big test, or you have a big project, or there's a very stressful time in your life, and you're able to push through it, but right when that stressor is gone, all of a sudden you find yourself catching a cold or something like that. Well, that's because your body system was impacted, and the weakened immune system can't really handle and fight off any of those pathogens anymore. The person becomes more susceptible to disease. This stress recovery, you can either remove or reduce the stressor. There's biofeedback training, exercise, meditation, relaxation. And interesting, of course, here is you see that exercise is on one of our recovery methods for stress fatigue, whereas for the physical fatigue, people should be reducing their exercise. And this captures really how different types of fatigue do require different modes of treatment and recovery. Unemotional fatigue is just what it sounds like. This was that psychological fatigue from our earlier slide. This is related to emotional events and reactions, mood disorders and mood disturbance. People feel irritable, kind of dulled, a hopelessness, lack of motivation. And our recovery methods are really therapy, for example, meditations and yogas, exercise, again, getting that body going, self-care, and sometimes a medication treatment with a psychiatrist if that's indicated. And what brings us all here today, what I am here to talk about is our neurofatigue. This goes by many other names, and it's often mental fatigue in the literature, sometimes cognitive fatigue, but I personally prefer to call it neurofatigue. And so that's what you'll see throughout today. You can see this kind of lengthy definition here at the top, but what it's highlighting is that neurofatigue is a range of exhaustion experiences that the person is noticing. There's a different range of duration of symptoms, and that this is really specifically brought on by a mental exertion, a cognitive effort. This is tiredness of the brain. But this is a different kind of tired. So the general population can say, oh, I'm so tired. I really want to go to sleep. I need to rest. They rest, and lo and behold, they wake up and they feel better. That's a normal fatigue. But a neurofatigue doesn't necessarily respond to sleep or rest the same way. And in fact, people who experience it don't always have that feeling of wanting to sleep. Sometimes they do, sometimes they don't. Fatigue can persist long after a person has recovered from other symptoms of an injury. It could be physical, visual, cognitive, and that fatigue could still be lingering and then actually impacting all those other symptoms. In the case of neurofatigue, this mental exhaustion is associated with a sensory stimulation typically, or you see here is the invasion of the senses. Think of light and noise sensitivity that's so common after brain injury, as well as a prolonged cognitive or thinking activity. Really typical of neurofatigue after brain injury is that there's disproportionate and variable recovery time that is needed. So this means that it's almost like a fatigue hangover. There might have been a stimulating event that happened yesterday, and a patient will come in and feel surprised that a day or even 2 days later, they still feel tired. That's because it's taking longer to bounce back, really. After brain injury overall, right, the brain is feeling tired quicker than earlier. It's more overloaded after a tiny load, meaning some people will say, I used to be able to do this just fine and I didn't get tired, and now look at me, I can't even do part of this activity. And this can happen even after perfectly enjoyable activities. Listening to music, dining out, talking with friends, people can still walk away feeling tired. And that surprises them the most because they'll say, well, I didn't do anything stressful. But it doesn't necessarily take something stressful. It also feels like this fatigue comes on rapidly with little warning. Why you see a little asterisk here, I will get to later because it feels like this, but it is not always the case. Now, all of us can experience neurofatigue. It's just that after injury, right, this is more of what we see is just how quickly it comes on, how little things trigger it. So, while someone without a brain injury might feel like, oh, I got really tired, by the end of the work week, Friday evening, well, someone with a brain injury and then neurofatigue may find that it's only Monday and they just did a few things and they're already tired. So let's capture what it is here. This is a sense that the brain is not working the way it normally does. And that's what people usually say and describe to me. There's decreased productivity and or efficiency, right? Just because people are doing things and active doesn't mean they're necessarily doing it in the most efficient way, which is really key, especially for our high functioning go-getters that are doing a million things a day and not feeling great. Well, they might be productive, but they're not being efficient. It can really vary from person to person, hour to hour, day to day. It fluctuates. And again, injury to injury, it can be very different. As I like to say, when you've seen one brain injury, you've seen one brain injury. Everything is unique and different. And the same is true of neurofatigue. Let's get a few things out of the way though. What neurofatigue is not. It is not doing too little. In fact, it's usually the opposite. If people are doing too much without realizing it, because the definition of too much has changed. It is not a lack of stimulation. Sometimes people say, well, I just kind of stayed home all weekend. I didn't actually do anything. Actually, there's usually a subtle overstimulation going on that we need to take a look at. And absolutely most importantly to me, this is not laziness. The literature finds that as many as 30% or family of friends have interpreted fatigue as laziness. And the worst part is when I start to hear my patients interpret that for themselves, that they're being lazy and they didn't do anything. That is not the case. People are just trying to do too much. They're running out of energy and they usually want to do more. They simply can't. Now, I like to use metaphors for things, so let's think about this. I think of neurofatigue as a car's fuel tank. After the injury, the tank is smaller. It just can't hold as much fuel. And so it's all the more important for somebody to monitor their fuel levels as they go. They also probably need more stops at the gas station so they can refuel the tank. But if they're not carefully watching that, they might run on empty. And hopefully that's not on a parkway or something. People have to be a lot more conscious. Now, another reason I like emphasizing this kind of change in the fuel tank is that it removes some of those feelings of guilt or self-blame, because the injury has shrunk the tank, right? It caused a change in the system. And to treat it does require some work by the patient, but it's about changing how they're driving. So what are some of our typical symptoms? The literature kind of divides these out into some of the main categories you see here. You can see cognitive, physical, some stress, some things that look a little bit more like emotional, right? Tearfulness, the cognitive, again, with that slowed thinking. These are kind of our broad areas. But I actually find it helpful to dig even a little deeper, and I break them down into these kind of the big quality of fatigue. Now you will notice that a lot of these categories and symptoms kind of match with some of those things we saw earlier. Yes, they can overlap, right? Somebody can have depression and then have a brain injury and feel neurofatigue. Someone can have migraines that they had before and then be experiencing neurofatigue now. We're really not ever going to be able to say something like, oh, well, 80% of your is emotional. That isn't the point, and it just doesn't work that way. But we do need to understand the elements so that we can provide adequate treatment and incorporate and refer to other individuals and professionals as well. So, you know, we know that brain injuries don't discriminate, and we need to think about all of that. So just treating the neurofatigue won't necessarily resolve other symptoms, but we do need to kind of figure this out. So what are some questions that I ask people? Well, I like to look at what triggers the fatigue. Do my neurofatigue strategies, which we'll talk about later, help the symptoms, and to what extent? And I'll admit it is an experiment sometimes, right? And it takes trying different strategies to see what works best and when. But think of it this way: if we're using our neurofatigue strategies and it's eliminating, say, the irritability a person experiences, well, then that's telling me that probably it was the neurofatigue that was setting them off. However, if we use all the neurofatigue strategies in my magic bag and someone is still feeling irritable, stressed, or moody, well, then we might have more of an underlying emotional component, and that needs to be dealt with as well, right, with a primary treatment. That's when I'm going to be finding our social workers and our psychologists to refer to. So that's kind of an example. This just shows how broad it can be felt. So we know what it feels like. What does it sound like? Our patients come in all the time with very different descriptions of neurofatigue, and you can see a few small ones here, right? And oftentimes what I hear from people is that it's really hard for them to describe it. They'll come in saying, oh, this is going to sound weird, but, or I don't really know how to describe this, or I feel like I'm crazy, but here's what I notice. And this is really important to pay attention to. You might be hearing it expressed like this, what you see here: a fogginess, a haziness, just not feeling like themselves anymore, or not feeling quite right. And we need to pay attention to this, and as providers, be on the lookout for comments like this to think, maybe there's a neurofatigue under the surface. This is a little longer, but this is a really eloquent description that a patient of mine who has a mild traumatic brain injury wrote, and they are suffering from neurofatigue, and they're in treatment for that. And they shared this with me and gave me permission to share with you so that you could see just the complex nature of it. And I'll let you kind of read this, but notice, first of all, how many words he puts into this just to try to capture what it is, and how there's this sense of kind of helplessness sometimes, which is sometimes you do something and you don't know why it changed things, and other times you're doing everything you normally would and you feel different, and why didn't you notice that before? So take a moment with this. Again, I hear such poetic and eloquent ways of describing neurofatigue because people have usually been sitting with it for a while and have been racking their brains trying to figure out just how to share that with people. Let's talk some triggers. Now, in our definition earlier, our big two, right, were sensory stimulation. This is our bright lights, our loud noises, environments that incorporate this, right? Surely you've heard from people or know people and they just hate going to things like grocery stores and Walmart and places after, because think about it, it's lights, it's noises, it's crowds, right? Then the other part is that extended thinking and cognitive effort, right? Focusing for a long period of time, trying to multitask. I hear so many times people say, I just can't multitask anymore. Conversations, even fun ones, but when you're trying to balance more than one person, your brain is having to work overtime for that. Work and school, especially if somebody has some sensory symptoms like visual, screen use and driving, and really when people are working, whatever they're doing for extended hours without a break. Neurofatigue has some significant implications really across different settings and for recovery in general. At home, we can see that someone isn't able to engage as much in their own, maybe even their own care, as well as activities they would normally do around the house. People can slip into unhealthy habits easily, right? Planning a whole dinner for yourself or for a family takes a lot of work, plus the grocery shopping, a lot easier to do something quick or just to kind of not eat as healthy or decrease eating at all. Sleep routines get thrown off because habits are changing. Overall, there's a decreased independence. And this, of course, can have ripple effects, right? This impacts other relationships, either because of the symptoms or people feel that others in their lives don't understand what they're going through. And of course, there can be an increased stress and burden on caregivers and family, especially if that independence is decreasing and decreasing. Well, someone's picking up that slack somewhere, and it's probably these folks. At work, there can be a lot of missed work days because they're just too tired to go, or the symptoms are so high. Overall productivity and performance is lower. This can put employment in jeopardy, right? People might be at risk of losing a job, or if they haven't been able to return to work yet, this can delay it, and they might not even be able to return to work. Remember earlier, we said that this fatigue is a big piece of whether people have to go on disability or SSI. And the same is true, we could carry similar over to school, right? Missed school days, difficulty completing homework or returning to school activities. Within the treatment setting overall, we can have reduced engagement in our rehab therapies. This could be because there's a decreased endurance, the person can't focus, they're missing sessions, and so we lack this kind of consistency and carryover. There's going to be a harder time meeting all the treatment goals, and this especially becomes a problem because this can impact insurance coverage. So a lot of insurances need to see progress, and if progress really can't be documented, either because of missed sessions or poor carryover, treatment might be cut, and then the person's without what they need as well. And of course, you can have reduced carryover. You know, our rehab sessions are really only one part of the week, an hour or a few or a half-hour sessions, and we need people carrying over these things to home to generalize them. But that might be more difficult, either with cognitive symptoms because they're forgetting and they're not focusing, or they're just tired and they don't feel like they can do this at home. Recovery overall can be longer too with this fatigue. Pre-morbid or issues that were there before can be exacerbated. So if somebody was, had physical symptoms before or a sleep issue before, that's going to get worse. We can also see a whole batch of new symptoms kicking in. This is especially true, I find, with mood. We get these adjustment-related disorders, right? A person might not have had anxiety or depression before, but because of their injury and the way their life has changed because of that, they're having trouble adjusting, and they would have a diagnosable clinical depression or anxiety. And that in and of itself impacts everything else. And engagement, physically, if someone's so tired, they're not moving around a lot, you can have, the decreased endurance and strength that will then add to what our physical therapists need to work with. And also, of course, when you're not able to do as much and you're not sure why things are changing for you, that self-esteem can go down, and symptoms aren't getting better. That person's going to feel worse and worse and create this kind of vicious circle in terms of treatment engagement. So we do not want any of these things. We want our people in treatment, in their lives, focused and feeling more in control. So how do we measure fatigue? We know it's out there, we know it's prevalent. What do we do? How do we capture it? Well, I think the most important is what people are telling us. You saw those descriptions earlier. People are telling us just in very different words, but I always emphasize to people, they are the expert on themselves. They are in that brain and in that body 24/7. And so it's important that we listen to them, give them credit for understanding how they describe their fatigue, when they get tired, what makes them feel better. And that's, and the caregivers too. What are they noticing about this person? From our objective data, I'm a neuropsychologist, so I see people during these long cognitive evaluations and also for treatment sessions that are up to an hour. And I don't have a test that says, oh, you're at such and such level of fatigue that I've got them strapped to wires or something and I can tell this. I can't do that, but I can observe how they are doing. So on a particularly demanding task or something requiring a sustained attention, I can see, hey, are there more errors later in this task, more delayed responses? As the day goes on, are there more errors, poor performance? Is someone asking for more rest breaks? Are speeds slowing down across trials of something? Then I kind of start to suspect some fatigue. Or certainly increase in symptoms like headaches and eye strain as we go. Now, we also do have scales, questionnaires, and surveys, and you will see just how many are out there. And there are more, of course, than this. But despite the fatigue being such a significant issue, we don't actually have a single reliable kind of gold standard assessment. You will see a whole range here, though, and these are all great, and they're attempting to capture fatigue. Again, this is usually subjective experiences. Some of these were developed maybe for MS, or you'll see even one capturing fatigue and rheumatoid arthritis, and people have kind of altered it. Some have been made specifically for our TBIs, like our Barrow Neurological Institute fatigue scale. I'll show you a snapshot just of a few of them, and so you can kind of see the range of what symptoms they're capturing, which is the full range of thinking and physical and engagement, right? I'm easily fatigued. How much do you agree with this? My thinking has slowed down. I have trouble concentrating. Moving my body is no effort at all, or is a tremendous chore. Over here on the left on a more visual scale, I have no desire to lie down, or I want to lie down. So again, kind of a range of different options and topics for capturing that fatigue, used very differently across certainly different research and different sites. Now, important to note, though, is that relationship between the subjective report, what we're hearing from a person, and objective measure, like one of these surveys. Sometimes that relationship is inconsistent, right? The literature finds different things. Sometimes someone can report a great amount of fatigue, but maybe the measures aren't really capturing it. And really the key there is just, if they're inconsistent, don't throw out all the evidence. Listen to both. Like, why is the subjective report so high and it's not being captured on a measure? Is it not answering the right questions? Is there an awareness issue or a denial issue? But we also do sometimes see connections, right? And when we do, overall, when there's more fatigue reported, we see that there's a greater impact on attention, right? And attention scores. This is the case with not only attention, but a psychomotor speed or processing speed. Executive functioning, that's our higher level thinking skills, right? Problem solving and visual planning and things like that, organizing. And that's the case with our traumatic brain injury subjects compared to the healthy controls. So with some of this research, we see these, quote, cognitive fatigability domains. Now, fatigability is just an objective change in a performance. It's a susceptibility to fatigue, right? And because of where we see it really hitting, we see an attention fatigability. So someone's more susceptible to having their attention fatigued. Executive, that's that executive functioning, or psychomotor, that's our speed fatigability. So what causes this great mysterious thing? Well, the mystery remains a bit here, right? The exact cause is not totally known. We do know that changes are occurring on a cellular level, very small. That's why a lot of scans and things aren't going to pick up a neurofatigue necessarily, and why we don't have a gold standard for, say, measuring that fatigue. But there are a number of theories out there, and I'm not going to go too in depth, but I'm happy to provide certainly more information on these in the literature. You can look for them as well. But here's a few of our suggested culprits. So one has to do with astrocytes. These are kind of our supporting cells of the brain. And if our systems are disrupted there, you kind of have this dysfunctional support for your whole neurological system. And so astrocytes are one what they're looking at. This can include neuroinflammation, a low-grade inflammation of the cells, including those astrocytes that can occur after brain injury, which again is making the whole system a little less efficient. Glutamate is also been involved. This is essential for our information processing. This includes learning and memory. And so our astroglial cells are usually helping clear this space between our neurons. They kind of clear the glutamate out of the way, but this is disrupted. So we get changes in how much glutamate is still hanging around in these extracellular spaces of the brain. And this is, this is a finely tuned system. It's important for all these things to be working and for the right amounts to be where they need to be. Dopamine is another one. Of course, dopamine is involved in so many things. And they're finding with something called the dopamine imbalance hypothesis that dopamine levels are disrupted. And this can really impact a whole lot of different systems. This is, why we see that brain injuries that involve a diffuse axonal injury, DAI, you'll see that they're less efficient and there's more effortful processing overall. We've also seen different genes that have been linked to sleep disturbance and even circadian rhythms, and those can be disrupted as well. But really the way to think about it is that our mental activities need resources and fuel and energy. And after an injury, the whole system is functioning less efficiently on this very tiny, tiny level, this biochemical cellular level. And that's why there needs to be this almost longer recovery time, because it's slower, it's taking longer. This is also why, for my mild traumatic brain injury, my concussion folks, they go get these scans, CTs and all these things, and it doesn't show anything. And we expect that with concussion, but people still have such symptoms. And that's because, again, look at these changes happening on a too small a level to capture right now. There's also different aspects of the brain, neuroanatomical networks involved, certain structures. We see the caudate nucleus, we have our ascending reticular activating system. The RAS, reticular activating system, is something involved in our arousal and our sleep-wake cycles. So they think that some injury to this part of the brain can result in fatigue, hypersomnia. You'll also see down here, I have these different proposed networks, right? So this is these changes that happen across the brain. There's not just this one part of the brain we can pinpoint and say, there's the fatigue spot. Look how spread out this is to all these different areas, whether you know what these areas of the brain are or not. It's a number of them, and it's spread across the whole system. So that's why I think neurofatigue becomes such a, first of all, a multi-dimensional, multi-symptom issue, and why it can be really difficult to capture and treat, because look how much of the brain is impacted. Now, from a treatment perspective, which is, I'm here to talk more as the treatment person with you today, it's not my role to fix these root causes, right? I'm working with the aftermath, but I wanted to share this with you so you could see how far wide reaching these implications are. Now, we can't really talk about fatigue without taking a moment to talk about sleep, because of course, people come in and they say that their sleep is off or they feel tired. So sleep disturbance, right, can be a secondary effect of the primary brain injury. Someone gets a brain injury, they end up with a sleep issue, right? Insomnia, sleep apnea, narcolepsy, all these different sleep disorders are more common in the TBI population compared with general population. And this is often untreated, actually, and undertreated. But of course, someone could also have a pre-existing sleep disturbance. Maybe they had a sleep apnea before that was never caught until later. And so, which one is feeding into which, it's hard to say. But I think what then makes it so important is that in order to pay attention to this, whether it's a primary or secondary sleep disturbance, we need to be collecting a comprehensive history, right? Were there sleep issues before? Have there been sleep studies before? Was the insomnia always an issue somebody had? Or was it ever since the injury? It seems like these things have been creeping in. And also what's causing some of the sleep problem, right? If there's an insomnia, well, are thoughts racing at night because of they're having a hard time falling asleep? Is there a physical pain and discomfort that makes it hard to find a comfortable position, causing someone to wake up throughout the night, therefore disrupting sleep quality, right? These are all important things for us to be paying attention to so that then we can provide adequate follow-up. Now that follow-up could be a sleep study, right? Getting to a medical provider, perhaps a psychiatrist for medication management, a psychotherapist to do sleep hygiene, probably, honestly, a combination of all of these. But that's why, when is fatigue something else? We do need to rule out the sleep disorders, and not even rule out, but really identify and treat, more importantly to say. Now, fatigue can also have an emotional basis, right? If with the fatigue, there's a decreased interest and motivation, hopelessness, anhedonia or loss of pleasure, we need to be thinking about our mood, right? Especially depression, which can really impact the sleep. Sometimes people have a PTSD depending on their injury. And when we're suspecting that there's a mood component, not to say that neurofatigue is not also there, again, get them to a medical provider, get them to a psychiatrist and a psychotherapist. And biologically, we can also have some other physiological issues going on as well. There could be an anemia, a thyroid problem, low thyroid, maybe endocrine issues or vitamin deficiencies. There's a number of people that end up with these vitamin B12 deficiencies. And so again, referral, bring in our medical providers. Let's get blood work to rule out or to rule in any of these biological causes of fatigue and then treat them in the same context with the neurofatigue. It doesn't always have to be just one thing or the other. People and brains are complex. We want to make sure we're thinking about every possible element and making sure that person's getting the help they need. So now we've learned a lot about neurofatigue. We know it's very much out there. How do we treat it? What do we do? Well, unfortunately, there's no magic cure for neurofatigue, and there's also no set time frame for recovery. Some of the research has found that fatigue improves in the mild TBI population, remains stable and moderate, and worsens in severe. But that study had a severe limitation, right? It only includes people who were hospitalized versus our MTBIs, where often they don't make it to a hospital or a hospitalization. And so overall, again, I see people of all durations since their injury, all types of injury, all ages and genders, and people can be at a total different range in their recovery. But it's important to still say, no matter where you are in that, we can still do something about that, even if we can't make the fatigue go away. We hope it improves over time, and in a lot of people it will, and that's great. But again, for others, we're going to see that pathological fatigue persist. And we have to take that into account too. When we're seeing people that have had fatigue after a brain injury for 3 months or even a year after the injury, we kind of have to assume and share with the patient this expectation that this is going to be present and a relatively stable thing in their lives, and it's most important that we manage it and deal with it. Now, there are medications, though, that we can use to help with neurofatigue. I am not a prescriber. As a neuropsychologist, I cannot prescribe, so I'm not here to say too much about this, but to really capture at least some of our options, or certainly if you have a patient with neurofatigue, important to get them a prescribing provider who can take a look at some options. So neurostimulants, this makes sense, right? Because you're stimulating that brain, these wakefulness promoting medications. Methylphenidate is very common. And a lot of these you kind of get used to hearing people on after brain injury, amantadine, which has been mentioned in some of the other presentations today. But this has been found it can combat fatigue. And in the case of methylphenidate, and even amantadine can help with some of the cognitive elements too, like processing speed, working memory, and attention. Antidepressants are another common thing that are being used to treat. Now, are they treating a sleep and a depression symptom versus that primary neurofatigue? It's a little bit of a mixed result. We're not quite sure, but if it's helping, and that's great. So something important to consider. I would caution, though, with the medications is sometimes people are on a lot of different things. So whoever their provider is who does the prescribing is going to want to pay attention to either interactions of medications as well as any contraindications, because some medications can help with sleep, but they can negatively impact cognitive functions. And so we want to be really careful there not to actually add more trouble to the situation. And certainly, sometimes a neurostimulant can increase heart rate or can cause increased anxiety. So we're going to really want to know that person's history before we start throwing things in there. But overall, patients and families, you want to discuss a neurological history or a brain injury history with a prescribing doctor. Even if you're going to someone for the sleep issue, they need to know that history for you as well. And our prescribers, it's important to take that full history to understand anything going on, stuff that was there before and stuff that's there now. There's also some wonderful non-pharmacological treatments. Mindfulness, one of my favorites. I do this in my treatment. There's been great results that shows mindfulness-based stress reduction programs can relieve fatigue across a number of neurological and brain injury conditions. And so we love to see that. And this is not only in self-reports, how the person feels, but even on objective measures, processing speed got better. And my colleagues have done research on mindfulness-based stress reduction program in brain injury and have found that the attention also improves. So there's another little side benefit there. Yoga is another great one. If you haven't heard of the Love Your Brain program, I encourage you to look it up. This was started by Kevin Pierce and his family. Kevin Pierce was a famous snowboarder who had a brain injury and found a lot of benefits in his recovery from yoga and has this wonderful program, a lot of great resources. So check that out. Aquatic-based physical therapy as well as blue light therapy are also non-medication-based treatment approaches that have been found to help with fatigue. But what do I do? So I work on a managing of symptoms. Again, you see me emphasize this a lot. It is not a cure, right? This is not a total removal of symptoms. This is kind of an acceptance that right now we have fatigue. Remember, it's probably kind of a stable present thing we have to live with. But we can take active steps to feel better, reduce the severity of that fatigue, shorten that recovery or bounce back time, really help somebody optimize how they're living their life. And it's done by learning about and practicing new ways of doing things. My key phrase I tell people is always do, but do differently. I'm not here to make you stop doing things. In fact, that's not a helpful thing. We want you doing things, but just doing them a little differently. So how do I train people to manage symptoms? Well, this is all about energy management, right? And being more efficient with that. And I do this through kind of these 4 overarching steps, right? Awareness. Somebody needs to be aware and accepting a bit that their symptoms are there, what are the triggers, and how to kind of just know what's going on. What is the neurofatigue? A lot of education goes into that awareness piece. Acquisition is learning strategies and tools, which I'm going to talk about in a second. And application is using them in the moment, right, to change the behaviors, to do differently. Throughout the way, even after you have a whole bucket full of tools, someone's still going to have to monitor themselves as they go. Because as we know, neurofatigue can change hour to hour, day to day. And so we want to make sure that they're monitoring that. Awareness is really just acknowledging that how the brain functions has changed. It does need more support to function at its best, right? What are these signs and symptoms going on here? I look at neurofatigue and I study it with somebody by asking key questions, right? Again, they're the expert on them, so use them. What changes when you become fatigued? What does your body feel like, or what is your thinking or your cognitive processes like? Emotionally, how do you feel? We're capturing all those key domains, remember? How do you behave, right? People often have very different interactions socially when they're neurofatigued. And does somebody notice activities or environments or things that make them feel even more fatigued, right? Knowledge is power. We want to know all the different pieces of this puzzle. Next is our strategies, right? Acquisition, which is the learning, and the application, which is using those strategies. These are just tools and tricks, right, of how to manage fatigue. Again, you will see me emphasize not cures here, not cures. We don't want that expectation, even in the room with us. And all these tools can be used either in the moment, which is called an emergent kind of use, or even before somebody gets tired, anticipatory. That's the best, really, especially if we can get a combination going here. These kind of things are learned with someone like me, or maybe our other rehabilitation professionals. I'm fortunate, I get to work with a whole team of physical, occupational, speech therapists, social workers, and I can have the whole team reinforcing strategies across all the different settings, and that really helps generalize it and helps take it home. Friends and family and caregivers can be very helpful with strategies, especially if somebody, due to the injury, has a memory or an awareness issue due to severe deficits. Well, those friends and family members can help cue somebody or remind them to use the strategy. So it'll be just as important for caregivers and family to understand some of the symptoms as well. What are strategies? Let's get specific here, right? Here's what I call some of my emergent or reactive strategies. This is, you notice the fatigue in the moment. Oh shoot, I had better do something about it. And look at this whole range. And this is just a small set of options, right? I always tell people we want what's called like a menu of options. There's no silver bullet in the world of strategies. There's not one thing that's going to work every single day. It depends on the day. It depends on the fatigue and the particular symptoms of the neurofatigue that day. So for example, even though you see up here, I say, hey, watch a favorite TV show or play a game on your phone. Well, if someone has high visual symptoms, visual strain and fatigue, that is not a good strategy for them to rest. In fact, they're activating their brain even more. They're going to want to do the visual rest break, right? Switching away from screen time. You'll see the reducing stimulation, increasing maybe a physical activity, doing some breathing, or doing a different task. Some people think I'm making them do nothing. And I say, no, you could maybe do a different task, but just don't do one that's requiring so much of your brain power. So you want to develop this whole list with people. Some of these can be really general, like everyone can do a deep breathing and benefit from that, or meditation. And some will be really specific to the person. Get specific. In the moment, they're going to need to know without thinking what kind of things they can do. A more anticipatory, or I call proactive strategy, what are things that you can do to set yourself up for success so that before you even hit that barrier, hit that wall of fatigue, you've already kind of helped yourself, right? This is planning the week ahead so that maybe somebody knows they've got a really busy day. Maybe the next day they need to take it a little easier. Don't do so much. Write it out on the calendar even. Take lunch breaks and set boundaries each day. Looking at everyone who eats lunch at their desk, myself included, guilty, but still, right? Create these boundaries so your brain has a chance to shift between activities and to rest. Regular physical activity, right? You saw in the previous slide, I say, hey, do a physical activity if you find yourself fatigued in the moment. Well, proactive would be make sure that's already built into your schedule. Maintain your wellness visits with doctors. Schedule enjoyable activities too. Break tasks down. Keep a healthy eating and sleep habits. And be writing things down anyway. So these are all things, again, stop, be specific. Write all these things down. Help a patient identify these. That's what I do. We sit down and we make this whole menu of options. Now, how I also apply these strategies is in treatment, we practice these using hands-on tasks usually. So that could be games or puzzles, but I usually am trying to actually elicit fatigue. I'm trying to make them tired, wear them down a bit with cognitive demands, because then I want to see them use strategies. Early on, when we're building awareness, people usually don't know to use them, and I'm having to prompt them. I'll say, hey, I see those eyes you're rubbing your eyes, or you're starting to make mistakes, or you're rushing. I think you're getting neurofatigue. Let's take a short break. And I'm guiding that. But the goal is that for that person to internalize that, be aware of those symptoms and use it themselves. Again, of course, if there's an awareness or a memory issue, depending on the deficits following brain injury, a person might continue to need prompts and cues from a caregiver or a provider, but that's great too. Bring someone in for family training, help train them so that they can be that guide for this patient. Now, again, strategies are different for everyone. You saw I've got a million of them, but there is one that I am a broken record about. And you can ask any of my patients, they get tired of me saying this, they get neurofatigue just hearing me say it, but take a rest break. It's one of the most important things we can do. More importantly, anticipate the need for rest. Plan a break before you are tired. People think that sounds crazy, like, well, but I should just take a break when I'm tired. That worked before an injury maybe, but now before you're even hitting that wall, stop and take a break, because that is going to help a person maintain their energy longer. They're going to stay more efficient. And these can be very small breaks, right? These do not have to be anything long, right? Short breaks, just 5 minutes throughout the day. Again, stepping away from a desk to go grab a drink of water, go to the bathroom, having lunch away somewhere else, or moving rooms in the house can be really helpful. Sometimes you do need the longer break, but short is great. The more, the merrier. Rest also does not mean doing nothing, and it doesn't mean just stopping and sleeping. People fight me on this a lot, actually, in treatment. They say, well, I can't do nothing, like I have to be doing something. Okay, so let's figure out what you can do that's a little different than whatever was fatiguing you. Again, can you do something that's not so cognitive? Can you put away the taxes and do something fun instead, or go for a walk? You can still be just as productive, but you got to switch it up. Also, family members often will say, well, the person's doing nothing all day. Well, this is also why we have to provide that education and communication about what rest is and what rest is to the person. Again, I got a lot of people that if I really made them stop and do nothing, they would go nuts. They're the people that need to be doing things. So in their case, we're switching what they do. Other people really do need to stop, rest, take a power nap, or just close their eyes, and that's fine too. But this has got to be personalized and tailored. The key is, though, don't overdo it. Don't push the limits. And that's why I say take a break before it is perceived as needed. If we use the strategies before it's too late, that really helps improve that recovery time. If we wait too late, sometimes that recovery time is going to be longer, and then they will feel like they were less productive that day. Now, you remember that asterisk earlier. I said that people feel that neurofatigue hits them out of nowhere. Well, I know it feels that way, especially early on before they know and they're aware of their symptoms. But really, the brain is constantly sending signals and hints that it is getting tired. We just aren't listening. And so that's where that awareness is saying, listen to your warning signs, right? So our brain injury survivors, they benefit from learning how to listen to their brain, right? That's that building awareness so they can monitor their symptoms, so they can change their behaviors and they can have better functioning. Initially, it's helpful to have providers. So I'm doing it in the room with people saying, hey, I think you're getting tired and here's why. But also caregivers and family members who might be with that person a lot more often during the week. Oftentimes people will notice this and they'll be able to say, well, you always get snappy when you start to get tired. Take that information in, that's helpful. Now, how I increase some of this awareness is I develop what I call a cognitive energy scale. Again, this is not the only way to do it. This is just one example of what I do. And this is a numerical scale. Now mine is 1 to 5 scale, but it could be 1 to 10. It could be anything you like, as long as you develop it with the patient. This is like learning a new language together. It's a language of numbers that correlate with symptoms. That way, when someone says, oh, I'm at a 3, I know what they mean. Family members, caregivers, they know what they mean. And they know exactly how they're feeling because we've kind of tied certain symptoms to certain numbers on this scale. Just like some, in physical therapy or another therapy, sometimes we'll say 1 to 10, what's your fatigue, maybe a physical fatigue. Again, this is the same thing, except we're saying, what's your cognitive fatigue? What symptoms are clustered around that number? Later, we're going to connect the numbers to a strategy. So that way someone can say, oh, I'm at a 4. That means I should be using the strategy. No, I write all this down. I make it very visual because that really helps a person remember it and code that information and better understand that. And key here too is we want to have someone notice when they're shifting. That's why I put it on a numerical scale, because the key is, are you moving up or down? Is that number changing? That means something is changing internally and we need to pay attention to that. So step 1, learn the symptoms, awareness. Step 2, learn and apply the strategies. That's that acquisition and application. And step 3 is doing those check-ins. What am I at? So how do I help someone check in with themselves? Well, I like to use a tracker. And so this is how they can familiarize themselves with this, quote, new language, is start paying attention, right? Track your cognitive energy levels. That's what that CES stands for, across the day and the week. Now, I just made this one myself in Word. You can make a similar table. And I really want people to overcheck themselves early. That's why I have every day of the week and I have multiple times during the day, because remember, neurofatigue can fluctuate and change. So we need to be able to capture that throughout the day. And by checking in on symptoms more often, what we're trying to avoid is that it came out of nowhere feeling, right? We'll start to see numbers slipping and sliding and we'll say, oh, what was happening here? So I ask people, ask yourself what number I'm at, jot it down in this table, and maybe jot down a few of your symptoms or some situations that were going on. They bring it into session each week with me and we collaboratively look at patterns. Is there all good energy in the morning? Well, great. That means they're at least getting good sleep. Or is it terrible in the morning? We have a sleep issue going on that, again, maybe we need to refer out to. Do energy levels drop every time they see the in-laws? Then we might have a little bit of a correlation there. But it's just important to know. Remember, knowledge is power. The goal over time is to transition off of this physical tracker, but really I want to ingrain it as a mental habit so that throughout the day, that person is then saying, what number am I at? What number do I think I'm at? And that way they can start to follow their own patterns and use their own strategies. This is all very adaptable to every single person. So self-monitoring, in treatment, any treatment provider can stop and ask for a neurofatigue level. Like I said, I'm lucky to work on this great interdisciplinary team where we can all be checking in on the same scale. That's really helpful. But even if you can't be working off the same scale, at least saying, hey, where are you at? Do you feel like things are decreasing, increasing? That could be from the start or end of the session, or maybe the start or finish of just an activity. So physical therapists might be doing this, on the treadmill, or OTs after a vision exercise, or speech therapist after a conversation group, or during a cognitive activity. And we're trying to connect those neurofatigue levels to functional activities. So a lot of times, again, people have this disconnection with this thing made me feel neurofatigued, especially when it's these great, pleasant, fun things, and they don't get that fatigues them, right? I went out to this really fun dinner. Well, that could have caused some of it, and we need to adjust that. At home, again, caregivers, family, they're encouraged to be educated on the scale so that they can have that shared language, communication. And at home, again, patients should be tracking their neurofatigue levels because we want to see some consistency, right? Just sitting in my session and telling me numbers tells me a little bit, but I want to know across the whole week, what is that really looking like? So let's revisit my car metaphor, right? Earlier, I said that fuel tank is shrunk, so someone needs to pay closer attention more often where their fuel gauge is. That's self-monitoring, right? But now we know it's not just enough to know how much fuel is in the tank, but how far we have to drive. What do I have to do with how much I have? Is there anything that I can do to store up more fuel for a big task coming up? Again, that anticipatory awareness. Do I need to plan some refuel stops along the way? I like to tell my patients that I'm the queen of metaphors, so I've got another one for you. This one is related to cell phones because I think people live with cell phones in their hands. This one usually resonates with them. If you let your phone go all the way to the dead battery, it's inconvenient. You are probably in the middle of doing something, sending a text, ordering something online. You have to go find the plug, find an outlet, plug it in. Then you have to wait for the whole darn thing to reboot, which takes a little bit of time. But if you recharged it before it died, your phone would still function. Now you might have to stop and still plug it in for a bit, but it's still working. You can still use it. And guess what? Your phone sends you messages, just like your brain does. Your phone says, warning, 20% battery remaining, 10% battery remaining. It's telling you, and the brain does that too. It says, hey, I'm gonna increase these symptoms to try to get you to stop and listen to it. And that's what that treatment is. Prepare, maybe even have a battery pack with you when you go. Of course, with brain injury, we can have a range of different issues and deficits with attention, memory, that awareness, or even organization and planning, the executive functioning. And so I really encourage people to use external aids. This is setting reminders and alarms. This says, hey, I'm gonna plan a rest break, and when this alarm goes off, I need to stop for a bit. Use apps for meditation. Have somebody track their CES levels, their energy levels on their phone in their notes section. Set a timer. Again, we want those rest breaks. Write handwritten notes to yourself around the house. I have people sometimes put little stop signs on their bathroom mirror, on their fridge, places where on their computer, places where they tend to overdo it and not really stop and listen to themselves. So have a note and a visual prompt there to make them stop and pay attention. And again, anyone in that person's life, involve them so that they can help reinforce all of these strategies. Overall, I think that what I want you to walk away from is that neurofatigue is real, it is common, and it can be persistent. And no one's going to come into you saying, I have neurofatigue. They're going to come into you with these odd and unusual descriptions, or they'll feel embarrassed to tell you how they feel, or they'll have so many other physical symptoms, maybe they don't notice that the neurofatigue is there. It's important for us to look at it, assess it, and take this very seriously, because this impacts recovery. It impacts return to activities and work and school. And it doesn't matter what injury this comes with, that just because something may be perceived and reported as a mild injury, we could have a very severe neurofatigue. And even though there's no single cure, which people usually feel very let down by when I first start talking to them, I emphasize that you can manage symptoms. And there's many ways, right? We have our medications, we have our meditations, we have these treatment approaches that I'm telling you about today, but there are ways to manage it, to feel better. Key in that is having a whole range of strategies and tools to use before you even need to use them, to take rest breaks, which again, does not mean doing nothing. It just means maybe doing something a little differently. And even though it takes time and energy, and I know my patients hate that too, they say, this was so much easier before I got a brain injury. I say, I know, I do know that, and I am sorry, but if you use this stuff, it works and it helps. And when the neurofatigue is addressed, what's amazing is so many other symptoms can have relief as well. Physical, cognitive, emotional, visual, everything, and just day-to-day functioning. Neurofatigue is often this weight pulling a lot of those down. And so by treating this, by helping someone manage it, they feel empowered and more in control of the symptoms. So instead of the symptoms being the ones kind of driving that car, the person's back behind the wheel, right? I'll sometimes tell people, again, queen of metaphors here, you're on a horse and that horse, look, was your brain injury and your symptoms. You can't help that you're on the horse, but what we can give you is the reins, we can give you the saddle and the stirrup, we can give you the tools to help at least manage how fast it's going and where it's going. And that's really the key, empowerment and awareness. And some references, again, happy to provide anyone with any information that interested you. And now I think Mary is opening it up to questions.
Yeah. Okay, thank you, Dr. Fultz. It's very informative. Let's see, we have a couple questions that came through during the middle of the presentation. This first one is, as a patient, is a primary care provider able to diagnose this, or do you need to go to a neurologist?
Great question. And that is one, it's tough because neurofatigue isn't really diagnosed by a lot of people until you get to a rehabilitation specialist or maybe a neuropsychologist or one of our rehab centers. So it doesn't require the diagnosis, but it could be something worth bringing up with them, that you have this fatigue, you have heard of neurofatigue, you suspect it's this, how can you treat it? I would love for it to be a more official diagnosis. I am on a personal crusade to get neurofatigue out there more often. It's still something being learned about. You know, we get insurance rejections all the time because they're saying, it's just fatigue. But I'd say primary care providers can certainly help connect you to the other people you need. So explain the symptoms you have of fatigue and then start asking, you know, who would be best to see about this. I think would be a good start.
Okay, another one came through and it said, your slideshow is very educational. Is it shareable to educate the writer's clients?
I think I have to ask, I guess, Mary and Jen. I'm not sure if we're sharing these later, or certainly if you want to send Mary your email address or contact information, and then I can touch base with you offline about how to share some of this neurofatigue information.
It should be up on the BIANJ website, so.
There we go. Yes.
Right.
The word.
I think that I heard it should be in about a week or two, right, Jen?
Yes, correct.
Okay. Okay.
And if you need more, I have some other slides and presentations and stuff out there. I'm happy to, again, connect you to more of the neurofatigue stuff because, yes, I fully believe it needs to be out there more often.
Is there a specific outcome measure that you prefer to use to help justify increased length of stays in rehab?
Oh, great question. That is something I know our office is currently trying to do some research on that fatigue element and looking at outcome measures. So our research side that's in the works. I personally I rely a lot more on probably on my observations here. So whether that's a perfect answer, not the case, you know, it might be nice to have something like that one day that does capture it better, but certainly in all my notes or when I'm appealing a rejection or something like that, I'm always talking about the symptoms, how I've seen them improve, and also, implications that that's having on a person's life or why they might need to manage that fatigue and what they're telling me as well. So again, not a perfect answer. I don't have a specific preferred scale or measure, but I think you could certainly incorporate any of those ones earlier just to look for change. Never underestimate the power of at least describing and writing about what you see and what the patients are saying.
Okay, right now there's no other questions in the chat, but we still have a couple minutes. So if anybody in the audience has a question, all right, here's one that just came. Okay, what have you found to be most successful when a patient is not compliant in terms of using various activating strategies to manage the neurofatigue?
I have run into that with some folks, again, especially when whether these are an awareness issue and they don't really see it, or they're just very high functioning and they just want to keep going and they're just, again, awareness or denial of an issue. To me, it's usually taking it up a notch in treatment, and I give them something really difficult, and then I exhaust them intentionally a little bit, and I say, oh, that kind of didn't feel very good. And then another day, or even within the same session, doing an activity and me making them take breaks and say, hey, how did you feel after that? Let's talk about that difference. Because once, I would say there's this aha moment when I can get someone to say, I took a rest break and it felt better, or I got to work longer in the day because I did that. I say, oh, there it is. That's what we needed. But like I said, I get a lot of pushback on kind of the stopping and taking a break. I get a lot of people fight with me about it. And I think it's just more, I keep bringing the awareness, but I try to make it happen in the moment. And I try and show them what it feels like, even if it's a little different, to say, try this at home. And then really even assign it as homework. I say, I know you won't want to do this, but I'm going to make you do this at home. Just try it at least once. Try it for me. And if you can get that buy-in, great. Sometimes you reach a point where in treatment, you've done the awareness, you've had them see it in session, and maybe even at home, and you might still get that difficulty employing the strategies. And that's a case where sometimes we just have to say, these strategies, you have to take them and use them and have a sit down, serious talk about it. And maybe they get discharged and they go out in the world with them, but I always leave the door open to say, come back if you notice that this is a problem still, or if you, find ways that you want to use this a little differently, because sometimes it's timing. Someone might not be ready for it yet. Having other team members is also very helpful, sharing those strategies as well, because sometimes I can't get someone to get it, but they really get it, with the PT or OT, and they go, oh yeah, that break was really helpful. So this is another good way too, if you can involve other providers.
Yeah, after the second or third hour of treatment, it sometimes things get a little better.
Exactly. Yeah. Yeah. When I've got someone at the end of their treatment day, if they've got a full program with my colleagues and I'm the last one, they say, oh, I hate coming to you because I'm always the most tired. And I say, I love seeing you at your most tired because I'm going to show you how we can work with that.
Someone is asking, in general, how long does it take to treat?
Oh, that is a good question. If I had the crystal ball on that one, I would be a lot better set up for requesting a number of sessions. I do not know that one. I will say straight away. It really depends on how a person responds. I mean, to some degree, the severity of fatigue, but I've had some very severe fatigues that, because they use the strategy so quickly, they felt better. And they'll still come in and say, I'm still tired, but I know how to work with it. And so the earlier you can get those aha moments, those connections to the functional activities or the buy-in, the better. But I've worked with people for a whole year. I've worked with people for the 8 sessions, and it is a range. It's a really, like I said, neurofatigue is so unique to each individual, and how they respond to treatment can be so different too. But the minute you tell them about neurofatigue, I find you instantly get some relief. I have a lot of people and they go, oh my gosh, it has a name, or that's what it is, or that's so me. Or I send them, a presentation and they watch it and they'll go, oh, it's neurofatigue. And that moment alone is really opening the door to at least validating and getting them somewhere, which is helpful.
Okay, I'm not seeing any other questions right now. I do want to let people know if you go into the chat, oh, there's a question that just came up, but let me just put in a little message. If you go into the chat, there is a link there that will get you to the workshop evaluation. Let's see what other questions we got here. How common is a physical problem, even minor, cause major neurofatigue? So how common is a physical problem, even if it's minor, cause major neurofatigue?
Okay, I see, and it looks like even something simple like, if I think that maybe that says eye infection. Harder for me to say because I work specifically with the brain injury, so I'm more used to, okay, there was a brain injury and then this is what we're viewing as the primary source of the fatigue. But certainly anything that your body is dealing with can make you fatigued because more of your brain's energy is going to that. So I think the asker, if they were saying like an eye infection, well, you know, you've got a lot of resources going to that. That might be more of a physiological fatigue, like the system might just need to be paying attention to that. But certainly anything that your body is facing can make you more tired, which is why, you know, even when we're sick, we rest and we hydrate and all of those things. So, but it is a very interrelated system. So anything that happens to you, your brain is the thing managing that, and you can have some neurofatigue there, no doubt.
There's another comment here. It says neurofatigue symptoms versus psychosis. Why not recognized?
I guess I'd want a little more clarification from the asker what you mean. I would I'll interpret it and maybe totally wrong. So if you want to write something more in here so we can read it and I can better understand your question, please. So I apologize if I'm missing the mark on this one. I'm wondering if you're asking if people almost think it's like made up symptoms or a psychosis when it could be neurofatigue. That could just be a mismatch in the provider not understanding what neurofatigue is. If it's the opposite, which is somebody having an actual psychosis or a psychotic break, that would be, again, more we'd have to deal with the mental health aspect first. But I would want some clarification on that one so I can make sure I'm answering that right. My only other guess is perhaps it's also kind of wondering about when is something like a psychosomatic, maybe like when people say, well, that's just made up, you know, that's not a fatigue, well, or that's not a real symptom. Again, that would be a provider education. If someone's telling you that, it might be worth getting more information or second opinions from other providers, or even trying to educate them a bit, or finding a brain injury specialist or rehab specialist, because neurofatigue symptoms are not made up, they're very real.
There's a comment here that just says, over time, can almost decrease neurofatigue if become better at tasks?
Absolutely, you can. If you do things differently, if you use these strategies, I'm a firm believer that you can definitely decrease the neurofatigue. You can increase that bounce back, right? How quickly you bounce back from it. And about becoming better at tasks, well, that just might be better at how you approach them and do them. Then yes, over time, definitely. Like I say, I always tell people in the moment, we just have to assume we're living with this neurofatigue, but it is also my assumption that with that adequate treatment, it does get better over time, but it's because you're actively using strategies. We do hope that naturally the system improves and the neurofatigue kind of naturally goes away. We hope, but we can't count on that. It would be nice to speed it along, which is what we do through the treatment.
Does this neurofatigue specifically have to involve a brain injury?
No, I would say no, because like I said, someone without a brain injury, we can kind of still experience, I guess, what you'd call a neurofatigue, which is that maybe you had a big presentation you were preparing for, right? And you had to do all this work and you're kind of like, whoa, I'm a little tired after this. My brain needs a rest. I'm gonna go watch a mindless TV show or something, you know, that's the neurofatigue. Or We end up in these overstimulating situations, a store, a crowd of people that none of us have had that for over a year, which maybe gave us a little bit of a rest, but anyone can experience that. The key is the general population, someone without a brain injury really isn't going to notice it as much. They're just going to say, oh, I'm kind of tired and I'll go do this rest thing and I'm better. Whereas with a brain injury, it comes on fast, it comes on hard, it just takes longer to recover, and it just hangs over the person for longer. So that's why I find that neurofatigue is just more associated with brain injury, because it becomes more impactful and more problematic than it would be for someone without the brain injury. And something like, you know, a burnout or an exhaustion syndrome might also have a stress fatigue involved in there. So it would be worth looking at some of the triggers and some of the other factors there.
And just the final comment, the person who had asked the question about the neurofatigue and the psychosis, I think is what she's saying is not understanding the symptoms or being familiar with the term neurofatigue.
Oh yeah, and you're right. This is a term, you know, whether it's the cognitive, I told you it has many names, right? So you might go to someone and say, oh, I learned all this about neurofatigue, and they're going to look at you like you're crazy. Like, well, what is that? You know, and there's cognitive fatigue, mental fatigue. This is something that honestly, I hope for the whole rehab and medical and every profession, I hope that this is an increasingly, I guess, talked about issue. So people do have that greater awareness of it. Don't feel put off though if you talk to even a neurologist and they don't know what you mean. Like I said, that's when I would say describe it in all the ways, the physical, the mental, the cognitive ways it impacts you, and how this, you know, you noticed it after a brain injury. Because you're right, it is a misunderstood and undertreated issue. You know, I feel so fortunate. I work in the whole BIANJ, you know, and people know what this means when I work with all these different providers and professionals, but there's a whole world out there that doesn't. And that's often why people get it treated so late after a brain injury, because it wasn't acknowledged or appreciated or validated, and why it can linger so long and people can just feel worse and all their symptoms can worsen. So, you know, it's not you, it's our systems that's got to learn a little more about it, but certainly take your symptoms, advocate and educate and share that with other people as well.
Okay, thank you. It was great. I think the participants seem to have learned a lot, and thanks again.
Great, thanks Mary. Thanks everyone for your attention and for having me.
All right, bye-bye, thank you.
Bye.
It was a good job there.
Thank you. All right. Thank you. Very excellent. Thank you for screening my questions, getting everything out there. That was great.